The next speaker will represent Kadimastem, and this is Dr. Kafir Molakandov, and he will be speaking about safety and efficacy of the first-in-man intrathecal injection of human astrocytes, AstroRx, in ALS patients, preclinical and phase 1/2A clinical trial results.
Thank you, James, for the kind introduction. And I would like to thank the organizers for the invitation to present our data. So today I'm going to talk about the results of the phase 1/2A clinical trial that we have conducted using AstroRx, human astrocytes, in ALS patients. We are a public company, so this is our disclaimer. So our vision at Kadimastem is to replace, restore, and repair the lost functionality of malfunctioning cells in degenerative diseases by transplanting healthy and functional cells. We use pluripotent stem cells as a starting material in order to generate these functional and healthy cells. So the rationale to use astrocytes comes from several publications demonstrating that ALS patients' astrocytes fail to function in several mechanisms. They don't secrete adequate neurotrophic factors. They fail to remove toxic factors like glutamate. They don't regulate oxidative stress, and they lack the correct immune modulation profile. So we suggest to use astrocytes, healthy astrocytes from pluripotent stem cells in order to support these all processes. So the slide that you see here is actually more than a decade work describing how to generate these astrocytes from pluripotent stem cells. We start with embryonic stem cells, a stem cell line which is GMP grade, differentiated into neurospheres, and then we have a frozen master cell and working cell banks of the astrocyte progenitor cells. These cells can later be thawed and expanded and differentiated into mature astrocytes. Our current version of the protocol is a frozen astrocytes, AstroRx, but the clinical trial was done with a fresh product. So our current version is thought to inject, and this is what we are going to use in our next clinical study. So the road to clinic, what did we do? We had to show to the regulatory authorities the characteristics of our cells in terms of identity, purity, and functionality. As you can see, the characterization of the cells by identity and purity marker, the AstroRx cells have astrocytic phenotype. They express GLAS, T81, CD44, aquaporin-4, GFAP, and nestin. And we established the release criteria for these batches of clinical AstroRx. In terms of purity and safety, we don't observe any residual levels of pluripotent stem cells markers like Tau160, SSCF4, or EPCAM. In addition, the safety profile of the drug product in terms of sterility, endotoxin, and mycoplasma viral testing is clear. Now for the potency assay, what these cells can do. So the first assay that we implied was the glutamate uptake, and you can see that these cells clear very fast the glutamate from the media when they are incubated with high levels of glutamate, very similar to the level of brain astrocytes. In addition, when we inhibited the glutamate transporter, we saw that this activity of glutamate uptake is inhibited as well. Another potency assay that we apply, we test what these cells secrete in terms of neurotrophic factors. So for this purpose, we did a multiplex ELISA for about 1,000 proteins, and we found about 40 proteins. Some of them are known to protect neurons, axons, or synapses. For ALS, we found mainly relevant that are osteopontin, TIMP1 and 2, tissue inhibitors metalloproteases, MITKINE, MIF, and CXL16. We see the effect of these neurotrophic factors in a simple co-culture with neurons when we don't add astrocytes, and here where we add our healthy astrocytes, you see clearly the new rate growth. Another potency assay that we applied is the protection from oxidative stress. When cells were exposed to hydrogen peroxide, you can see the level of apoptotic cells by staining for caspase-3, and you can see when even the medium of the astrocytes, nevertheless, the co-culture with the astrocytes reduced significantly the level of apoptotic cells. In terms of immune modulation, we see that incubation of lymphocytes with astrocytes in the presence of concavalin A significantly reduced the immune response in about 40% from the baseline. And the last potency assay that I would like to show you is how AstroRx cell product promote the differentiation and maturation of oligodendrocytes, and this is in all forms of incubation. You see this is the level of O1 positive cells without astrocytes, and this is with the supernatant, the soup, in transfer or in direct contact. In all these cases, we see upregulation of O1 expression with time. So to summarize about what these cells can do, they can act at distance by uptake glutamate involved in reactive oxygen removal, and secretion of neurotrophic factors and neurogenic factors. So we tested these cells in vivo in SOD1 model, and we analyzed it in the rat model, and we analyzed the parameters of survival, grip strength, rotarod, body weight loss, and paralysis. The injection was intrathecally, as we wanted to do in the same route of administration as we wanted to do in the clinical trial. And it's important to note, without immunosuppression, remember, these are human cells injected into the rat CSF. And we see indeed that the injection of AstroRx resulted in delay of disease onset, prolonged survival, improved grip strength, and improved time balancing on the rotating road. In terms of safety, before we performed our first in-human study, we had to perform a vast and in-depth safety study in immunodeficient animals. So we used about 600 NSG mice. These mice were analyzed after 4, 17, and 39 weeks. And what we have looked for is the identity of the cells post-implantation, and we see after 39 weeks that they maintain their astrocytic identity. And of course, we searched for teratoma formation, and gladly we didn't find any risk using these cells when they're injected into the CSF. Now for the results of the first in-human clinical trial. So the study was designed like that we originally had 4 groups in 4 cohorts, 5 subjects in each cohort, and the idea was to do a dose escalating assay. Due to the pandemic, we only could have accomplished cohort A and cohort B, which are 2 doses, a dose escalation assay, 100 million cells and 250 million cells. So the study was designed like that there would be a run-off period, a screening and a run-off period for about 3 to 4 months to collect the ALS-FRS and other parameters for the patients, to treat them with AstroRx, and then to do the follow-up every 3 months, every 3 months, and a follow-up up to 12 months. So we're talking about the single injections and follow-up. So we completed cohort A and cohort B, and as I said, cohort C and D that were planned were not conducted due to the DSMB recommendation due to the pandemic. So the first thing that we wanted to see is that the cells injection is safe, and the safety results were good. The product had a good safety profile. We didn't observe any treatment-related adverse events, and no dose-limiting toxicities were reported. There was no difference between the 100 million cells and the 250 million cells. The main parameter that we analyzed is the ALS-FRS, and over here we can see the results of cohort A. This is the run-in period. This is the first analysis time point, 3 months. and 6 months and 12 months. This is cohort A, cohort B, the combined cohorts A and cohort B together, and analysis of the rapid progressors. So the main thing that we learned from this study is that for the first 3 months, our treatment is effective and reducing the slope of deterioration very nicely and significantly, also in the rapid progressors, and without any change between the low dose and the high dose. So this was fine because in one high dose, we could actually treat 2 and more patients. But because we saw that the effect was only transient, after this study, we are doing another study. We are planning another phase 2A study in the US, in which we applied and we got the approval of the FDA to commence. And this study is going to test the repeated injections of AstroRx. In the meantime, as I told you, we are using a frozen off-the-shelf product, which means logistically it is much easier to ship the product anywhere. It's a thought-to-inject product anywhere in the world. And this is the study outline. So the first 6 months is a double-blind phase, and then it's an open-label extension. So the company is now commencing, in order to commence this phase 2 clinical trial in the US, is pursuing for funds in order to commence this trial. That's it. In that, I would like to thank the chief scientists of the company, Professor Michel Ravel, Dr. Michal Israel, and Judith Shabbat, that developed the technology, the patients, of course, and the employees of the company, the production, GMP, QAs, all that managed to make this project happen.
Wonderful, wonderful presentation. Thank you for the clarity. So we do have a few questions for you. So the first one is, does riluzole plus AstroRx clear faster?
Again?
So the question is, does riluzole plus AstroRx clear faster? And I'm not sure if this is from, I don't know, Ben, if you want to clarify that question. I'm not sure I can say whether you mean, does it clear riluzole faster or the AstroRx clear faster?
Well, the issue there is patients are on riluzole. So what is the interaction of the AstroRx with riluzole?
Oh, I see. You're saying is the half-life shorter of riluzole?
So we did in vitro studies combining riluzole and our cells, and we didn't find any effects that one on the other. In our study, the patients were on standard care, meaning they were on riluzole, so we didn't observe any signs that there would be a contradiction between these two drugs together.
Great. And then follow up to that question again from Ben. Do subjects develop anti-GFAP antibody?
We didn't test. We didn't test autoantibodies or GFAP antibodies. We didn't test, but the patients were not immunosuppressed. So apparently there could be instances of antibodies against antigens from our cells, although they are human cells in human settings, but in the immune privileged site, but there could be instances of antibodies, but in terms of inflammatory markers in the blood and all that, there was no induction of such inflammation or something like that. We didn't detect any change in the blood test of these patients, and we did monitor it.
Interesting. Could be interesting to look though for antibodies, but I see it. I mean, GFAP would be, I suppose, one, but it could be really any epitope on these cells so it would be could be a little tough. Did you do ELISpot tests by any chance?
Yes, we did, and we didn't find any immune response that is directed to the cells. This is why we think a repeated injection would something that suffice and the patient would benefit from.
Great. So then going back to the some of the preclinical data, is the eventual loss of effect in the grip strength attributable to a loss or degeneration of the injected cells?
Yeah, so we need to remember that although we saw very late efficacy parameters, more than 180 days in the implanted rats, these are human cells in a rat animal model. So there might be also issue of xenogenic cells in human cells in a rat. The second thing is that we have to remember these are constantly generating damage animals due to the SOD1 mutation in the brain. So we think there is a buffering that these cells are capable to do up to a certain point. Even they, although they are come with like beautiful, and Shiran mentioned it in her talk, that we are not looking at one target. These cells can do many things. These are factories of nutrients and factors and all that, exosomes and all that. They can do a lot of things, but they are under attack from the environment. So even they are failing at the end to supply what the environment needs. This is why the notion of multiple injections is something that we pursue.
So, and I'll just say there are a few questions about kind of the immune, sort of potential immune reactions and how you would monitor long-term for that. So I think we're hearing from the audience real interest in sort of how you're going to monitor for that. Do you know the biodistribution of the AstroRx cells?
Yeah. We had to do a clear biodistribution in the safety study that we do, and we only found them at the central nervous system throughout the spinal cord and in the meninges.
And when you did that, did you see reactive astrocytes in sort of the tissue?
We saw astrocytes. Yeah, we saw GFAP positive cells. They were still there after a long period.
Were there endogenous reactive astrocytes around them or microglia?
Yes, they were normal astrocytes.
No, okay. So then there's a question about the next phase 2A trial. How many people would you plan to enroll in that?
So just a second. Wait, for some reason for the phase 2A, the first, just a second. Okay, so we are talking about 20 subjects that would receive, would go to the double-blind phase, and another plus 10 subjects in the placebo group. And then after 6 months, it's going to be an open label. So the placebo group would get 2 doses at least of the AstroRx.
Okay, so 30 randomized.
30, yeah, total 30.
Okay, yeah, great. I will say that we hear again that the word of caution, and we've heard this in a couple of the presentations, and we're hearing from some early development programs, just the word of caution about looking at clinical endpoints in a very early stage trial, just small numbers. We know there's
these are 10 patients, and this is why we want to expand it in the phase 2A to establish the notion of making the disease more chronic using the multiple injections, and we hope to see the same results of the first 3 months.
Wonderful. Thank you very much for your presentation.